computer sir. Oh.
Right. Okay. So good morning, everybody. 149 anymore? Co-students are there? Are you all there?
Yes, sir, we are there, sir.
Right. Okay. So dengue fever, from where we stopped yesterday from the fluid point of view, we will move and see. So if you take this case history, a 5-year-old boy who was brought to the OPD with fever of 1 day duration with 1 bout of vomiting, paracetamol and domperidone was prescribed, and the fluid target was given and asked to come on the 3rd day of fever. Now this is of course a common clinical presentation, especially when you get an epidemic of dengue fever. So during this time, you don't have to admit each and every child, and it is not really proven as dengue also. So you have to see whether this can be managed at home or not. So what you have to do is you have to give them the important thing. Even if it is dengue, first 2 to 3 days, you don't get any problem. But the important thing is that you you have to make sure that the person is hydrated well. But the hydration has 2 important aspects. One thing is that it will help to maintain the fluid in the body. And also the other thing is, once you have maintained a good urine output, that will also contribute to the reduction in the body temperature. Because you all know in small children, there is an entity called dehydration fever. Because their reserves are so small that they can even develop dehydration. But if your hydration is very good, your circulation is good, and as a result of that, the blood flow to the peripheries is good. And you all know, when the blood is circulating, that is one way. When you perfuse your skin or mucous membranes, that will help to dissipate the heat from the body to a great extent. So then the important thing is, what is the fluid target you give? Now in a basic clinic, you can't be calculating to the decimal point. So what you can easily do is, you always get the weight measured in a child. You multiply the weight by about 3 or 4 milliliters per kilogram, and that would be a roughly hourly the fluid that you have to give. So if a child is 10 kilos, you tell them to give about 30 to 40 milliliters minimum during the hour when the child is awake. But preferably, the child should not be awakened during night or at any time of sleep. But if you give at least 30 to 40 ml per hour when the child is awake, roughly about 15-16 hours a day, that would satisfactorily give the fluid. So then the paracetamol dose should be given properly. Always, now this is therapeutic lecture, because of that you always calculate 15 per kilo. 15 per kilo is not always needed. It is actually 10 milligrams to 15 milligrams per kilogram. So always make sure that you round it up to a dose that can be given to the child. Now don't say that 137.5 milligrams of paracetamol should be given 6 hours, because you all know the available forms are either the syrup or the tablet. Tablet is only one strength, 500 milligrams. So the minimum you can go is about 125. That is also not very easy with a elongated tablet where it is scored only at the middle. So it has to be a dose that can be given, or it should be multiples of 24 milligrams or 12 milligrams maximum, because you can go for 0.5 ml of the syrup. So that way you have to make sure the amount you give is administratable amount. And then the domperidone, sometimes you may give it if there is any vomiting or nauseation, because otherwise, as we discussed yesterday also, if their child begins to vomit, then it will be difficult to give the high fluids, and hydration would matter. Then that could be an indication even to bring back to the hospital and admit. So at least till 48 hours passes, you should not be doing full blood counts. But sometimes what happens is the facility may be available. Sometimes some parents may be able to afford it from outside, and you suspect very much it could be dengue fever. Then you can do a NS1 antigen, but preferably it should be done 24 hours later and 48 hours before. So in the second day of the illness, you try to do it to get the maximum yield, because sometimes when they have done it in a mighty hurry, within first 6 hours, 12 hours of fever, it may not give a positive result and it can give a false negative. So then you will have issues related to that. Now, when you go on, now after the completion of 48 hours, they may come again on your advice, and you can see that the vomiting may have increased, headache, body aches, typical of dengue fever will be there, and then you can see a character, which is the flushness in the body, and then extremities may be cold. Test is a good test to be done to show the capillary fragility and easy bleeding. Then you examine the pulses. Pulse volume is good or whatever, you have to make a determination. Then BP may be slightly low systolic. Diastolic may be slightly higher than the normal upper limit, where the pulse pressure will become narrower. And at this stage, still the leaking may have not set in. Because of that, the lungs may be clear. There may be a little bit of hepatomegaly, because there are several mechanisms of liver damage. So one thing is, initial phase is that either it is due to the direct action of the virus, which causes damage to the liver due to the viral action, as well as the initial immune mediators that have been coming into place. And subsequently only one would get the features of congestion and causing liver damage or hypoperfusion. So at the initial phase, the hepatomegaly may be mild, but there can be tenderness because of the hepatitis that is caused by the direct action of the virus. Spleen is usually not palpable. So when you do the investigations, you can see the PCV slightly rising, then the WBC is dropping with the lymphocytic predominance, and then the platelet count may be below 150,000, but not has gone down below 100,000. So clinical diagnosis, even if you have not done the NS1 antigen, you can make a diagnosis of dengue fever at this moment of time. So still it has not progressed into dengue hemorrhagic fever. Now, when you look at the dengue classification, you can see that it can come as an undifferentiated febrile illness, or that is, it just goes, malaise will be there, mild temperature will be there. It will not really hamper anybody. And if it's especially not during the course of the dengue, people will not take much notice. In a day or two, things will settle. So no time even to do a blood count. Then of course, you will have dengue fever, dengue hemorrhagic fever with shock syndrome. You all can hear me? Hello?
Yes, sir, we can hear you.
Right.
Yes, sir.
And then
Yes, sir.
unusual dengue syndromes also can be there. Now, apart from this undifferentiated, now this whole thing will mount less than 10% of the all dengue infections. There is a large group of people in the community who will have inapparent dengue or totally asymptomatic. Unless you have done the immunoantibodies or you have done serially NS1, you will never detect them, not even see NS1. Probably later on you do antibodies, they will say, we have never experienced any illness, but the antibody levels will be positive. And then this group is, of course, behaves quite differently when it comes later on. So that's why sometimes we would see when we do dengue antibodies, IgG, IgM, both will be positive, and they will say they never had dengue fever. So this is also something which you have to remember in mind, because especially when you have to counsel the patients. So dengue fever definition, of course, you can go through the national guidelines. You can download the national guidelines from the epidemiology website. And case definition is when there is high grade fever, headache, and the characteristic feature is retroorbital pain. Even day 2 or so, if you put gentle pressure on the orbit, you will see that they will complain pain. So that is a fairly valid sign when it comes to diagnosis of dengue. Then myalgia, arthralgia, bone pain will be there. The rash is there, and then there could be hemorrhagic manifestation, especially a positive tourniquet test, but we will not very much see gum bleeds, epistaxis very frequently. So then there will be no evidence of plasma leak, such as pleural effusion or ascites, either clinically or ultrasonically. So when it comes to dengue hemorrhagic fever, but of course you can predict whether the dengue fever case goes into dengue hemorrhagic fever. By about day 2 or so, if the child is very ill and very in discomfort, especially headache, abdominal pain, then you have to suspect and be on the watch out. And that type of a child, even admitting quite early in the course, is fair. So the case definition of dengue hemorrhagic fever is high fever of recent history of acute talk. I mean, they will have high fever. Then there will be hemorrhagic manifestations. A positive tourniquet test will be suggested. Thrombocytopenia less than 100,000 and objective evidence of leaking either ultrasonically, which we now do very frequently, but of course clinically you will see that there can be pleural effusion or ascites. Now this is a flow chart where you see the dengue viral infection. As I told you earlier, about 90 to 95% will be asymptomatic or what is called inapparent dengue. That is, they are not visible to the outside from a clinical point. Then the symptomatic dengue will be about roughly maximum 10%. So undifferentiated fever, dengue hemorrhagic fever, and there can be unusual syndromes. So then the dengue hemorrhagic can go into grade 1 or 2 majority. A minority can have shock syndrome as well. So when you suspect, when do you have to suspect? Because this is important, especially even on the day 1 of the illness, where you will be able to, if the facility is available, you can decide whether we are going to do NS1 antigen on day 2 or so. So if they especially have headache with retroorbital pain, nausea, vomiting, a diffuse erythematous macular rash, arthralgia, myalgia, which is so severe that is early it was connotated as breakbone fever. That is as if a person having a fracture type of a pain that they were getting in. Then you can have a leukopenia, especially if the total count is less than 5,000. But you should also remember in the first 48 hours, it could be neutrophil predominance most of the case. So you should not get carried away saying, okay, this is a bacterial infection. No, it can be the early phase of the viral infection. Still, it is not progressed into the lymphocytic predominance, especially if it is a child above 4 years of age. So if you can do the tourniquet test, much better. So if it is positive, that is more weight for dengue fever, and platelet to be especially less than 150,000, especially in the first, at the end of first 48 hours, and increase in the hematocrit. Now, increasing the hematocrit, of course, is not that easy, because if it is a child usually below 5 years, you take the baseline somewhere around 30 to 32, and children above 5 years, you can take a baseline roughly as 35, and then see whether there is about 5 percentage points increase in the thing. So if the hematocrit is about 40, then you have to suspect, okay, this person either dehydrated or having leak in setting. So those two you have to remember. So you have to make sure that you have taken adequate history and corrected the dehydration before thinking it is totally purely hypovolemia also. So at the first contact level, as I told you, that is at the OPD, maybe within the first 48 hours, you have to make sure that you give adequate amount of fluid. So you can give this recommendation. Even for any other illness, this is a rule of thumb that you can use for home management. Because if you don't give a measured amount and you tell, okay, take enough water or any liquids, people will not be exactly know. So it's always get the level, because most of the houses can now measure, or even if it is, you can roughly give from the household measures like cups or glasses. That is always get best. Any infection, they should be resting, because there can be a transient viral myositis, even if it is not dengue. Then of course they can get compromise in the heart functions, and then they have problems. So paracetamol, as I told you, don't calculate at 15. You take the middle and see what is the possible dose you can give. So you can calculate for 10 milligrams per kilo and try to round it up to the upper part, and then you can see if you feel it's higher dose, you divide by 15 and see whether it is under 15 or not, or by the weight. Then avoid NSAID steroids. Under no circumstances you should give steroids for undiagnosed fever. And then full blood count at completion of 2 days, 48 hours you stay. Because any child who needs a full blood count before that, I personally think that warrants admission or immediate look at the count and then act, because it can't be a simple reason unless the child is very toxic, where you suspect a septicemia or something like that. Then you admit if the vomiting is there, where you can't give orally as we discussed yesterday. Then there is poor feeding and severe abdominal pain, because abdominal pain could be initial leaking state happening, especially in the liver, and the capsule getting stretched, and then that could be an early sign of leaking of the person. And especially if there's bleeding, obviously you have to admit. Then if there is cold extremities, as we discussed yesterday, that is where the circulation is now compromised, and then it is trying to keep away fluid from the skin, but to send to the vital organs. So at the expense of the warmth of the skin, that this is happening. So any cold line, any cold extremity would warrant admission, because they may not be able to look after at home, and they may be in a state where they can very fast go into shock if we don't intervene. And if the child is lethargic ill, which we told yesterday, that there must be a component of cerebral compromising the cerebral circulation. So these features, if that is there, or if the carer is very poor, unable to understand, will not be able to recognize any warning signs, then in those cases, it's always better to admit the child. So there are 3 main phases in dengue. The febrile phase, which could be looked after mainly at home. Then those who go into dengue hemorrhagic will have the critical phase. And once they have recovered from that, if typically 2 days plus, so anything 3 days onwards, you have to be very careful, especially if somebody comes with a history that there had been a past history of dengue fever, because then it is highly likely that he will be having now secondary dengue, which will push them into development of dengue hemorrhagic fever. So then, although we say that the critical phase runs for 48 hours, there is nothing to say it is exactly 48 hours. You can always have a little bit of a leverage going on to maybe about 60 hours or even 72 hours. And this is the most important period. And if you manage this properly, then you can see through without much complications. Then of course the convalescent will come later on, but of course the early convalescent also you have to actively manage, because otherwise there can be problems with fluid overload, which we'll discuss a little later. So you can see in the febrile illness, this comes down, and then you have to be very vigilant, where when the fever comes down rapidly. Because what we mainly do is we measure the temperature. We don't go into the core. We measure from the periphery. So now from the pathophysiology, you know, if there is hypovolemia, circulation is cut down to the skin, and then the blood is the one will keep the skin warm. So that means it will not reflect the internal temperature at the level of the skin. So at the armpit, when you measure, it will be less than the normal. So if a person has fever and then all of a sudden precipitously it comes down or touches the baseline, you can't be happy. You have to be more vigilant. Okay, this is a vascular compromise to the skin. So there must be leaking and hypovolemia setting in. So we have to look in and then see the vital parameters, pulse rate, blood pressure, as well as the CFTR, and then correct that if there are any changes. So, so the fever dropping is very, very important. So then, of course, sometimes you can become very, the fever may not totally settle during this phase. And then with that, they will gradually come, and usually if the fever is settled for 48 hours, things are more or less settled. And then you can be complacent and be happy. But of course, again, if there is a fever spike, you have to make sure that you are not dealing with any peripheral infection, especially there can be vascular site problems. So that also have to be looked into that. So as we said earlier also, when they come, because this stage, most of the children will be staying at home, so they can come with dehydration. So in this case, of course, the absolute volume of fluid in the body is now less. Then they can go into vascular collapse. So if the child comes actually with a stage of shock, you have to also bear in mind that they could have an element of dehydration. Yesterday we discussed with diarrhea, where there is a total fluid loss from the body. But then somebody asked whether in dengue also whether it happens. It could happen because not because of the physiological process of dengue, but because the process where the people have not taken adequate amount of fluid to maintain the requirement, daily requirement. So as a result of that, they can have dehydration in the initial phase. But if a well-hydrated child comes and then they go into shock, that is not because of dehydration, but because of the redistribution of the fluid within the body. It has not left the body. Then, of course, after shock, the problem is that we should not keep on giving fluid, because the fluid which has been now outside the vascular compartment keeps on coming into the vascular compartment. So then if we from outside keep on giving fluid to the IV through IV cannula, then also from blood coming from the outside will cause a problem to the heart. It may increase the pressures in the, or the peripheral resistance will be increased, and then the heart will have a little bit of difficulty in pumping blood. So then the hematological parameters, you can see that the hematocrit will keep on rising with the increase in the leaking, and then the platelet will come down. So when the platelet comes down to below 100,000, usually it reflects leaking has set in. Roughly that is where about 3 to 4 days of onset of fever. Then when you come to the peak, usually the hematocrit will go to the highest point and the platelet will be seen as the lowest. Then the WBC will also begin to, now the first sign around the midpoint of critical phase, you will begin to see that the WBC begins to rise. So when the WBC shows some amount of improvement from the lowest level, then it's again a sign of relief to some extent, where okay, now the leaking is going to gradually settle, or at least will maintain in the same phase and then come up, but deterioration is less likely. So that is the changes in the parameter of temperature. So all these parameters observing is very important, because this is the most important part you have to see, which you can't see from what is exactly happening, but these will tell you where we are dealing, because clinically the temperature changes, and then the laboratory-wise hematocrit and the platelet counts will give an idea where we are heading in as far as this bar is, or this column is, this row is concerned. So that way we can watch. Now, febrile phase will go on for high fever, 2 to 7 days, facial flushing, all this we discuss. Hemorrhagic manifestations, mainly cutaneous or mucocutaneous bleeds will be there. Then the total white cell count will be normal initially and then come down with gradually going into lymphocytic predominance. And the platelet count will come down. And if it is less than 100%, it is almost 100% can be in dengue fever. But some of the dengue fevers will also show a drop in the platelet count, but usually they will not drop very low levels, maybe around 80,000, 90,000 maximum. But the dengue hemorrhagic fevers will show a fairly reduction. Now, what will happen when the child is in the hospital is, day 4 of the illness, develop bleeding from gums. There can be hematemesis following melena. Child was treated with omeprazole and ranitidine. Now, sometimes we tend to put this prophylactically also, because that anyway there can be edema in the mucosa of the gut and the stomach, and their feeding is also less, stress is high. Because of that, the acid secretion could be higher. So in order to prevent any hematemesis or melena, some units prophylactically even start on omeprazole. And our experience is that we have not seen very much hematemesis or melena in our unit because of the probably commencement of omeprazole early in the course of the illness. So then what happens is, when it comes to the 5th day, that is after completion of 4 days, there will be signs of vascular compromise due to the leakage. So what you are giving is not remaining in the vessels and it is leaking out. So that will affect, or one of the first points that will be shown is the reduction in the urine output, which is a fairly objective measure. And then whole peripheries, and there will be episodes of hypotension. As far as they are lying down, things would be okay. But you have to make sure that you make them sit on the bed, and then make sure that the legs are kept aside of the bed, not on the bed straight, but you have to make sure that the legs are taken out of the bed and hangs from the sides, because we should allow the venous pooling happen there, because otherwise it will give a false positive or false negative hypotension evidence if you keep the feet or the legs on the bed. So you try to make him sit on the beds with the legs hanging from the side of the bed, and then wait for about 2-3 minutes, and then measure the blood pressure. And if there is a postural drop, you have to take it as significant. And then especially if the pulse pressure is narrow, anything less than 30, you have to be very alarmed. Less than 25, of course, you have to intervene quickly. So PCV would have gone very high, and the platelets also now would have even crossed below 50,000 mark. So these are some of the typical features that you will see in dengue hemorrhagic fever going into the critical phase and having a vascular compromise. Now, none of these are cut-off values. These are just only guiding values, but your clinical judgment, especially the blood pressure, pulse rate, postural drop, and especially cold peripheries is very important. You have to look for postural drop, because sometimes if it is an older child, 10, 12 years, they may not prefer anyone else coming with them to go to the toilet and washroom, and then they may try to go alone. And if you have not checked for the postural drop, they may sometimes collapse in the washroom. So you have to be careful and always try to make sure that a bystander is there and the toilet doors are not locked when they are using the toilets. So those are some of the other common sense things that you have to remember. So then such child should need resuscitation, because now you can see the blood pressure is, pulse pressure is 15 here. So you can't wait. So you have to give boluses. Now he is still in the compensated shock state. He's not gone into uncompensated shock. So you start with sodium chloride. So yesterday also we said we don't give colloids as the first thing because you are making the circulation still thicker because there is very hardly any fluid, and you give a colloid solution which is more thick that will clog the blood vessels, especially the microcirculation, and lead to organ damage. So you have to give a crystalloid. You can give 9.9% sodium chloride intravenously, and sometimes in such a case you may have to give even 2 boluses. So abdominal pain, as I said, and tenderness will be there. Then persistent vomiting, cold extremities and features of shock. Then clinical fluid accumulation, where clinically you will see the pleural effusion, but because with the ultrasound scan available freely, that will be seen. So earliest signs of accumulation of fluid is seen in the abdomen because there is a lot of dead space there. So the collection is easy here, and then of course in the pleural, which is clinically more evident to detect the pleural effusion. There could be mucosal bleeds, lethargy, restless, drowsiness, all you can see features of compromise of the cerebral circulation. And then liver enlargement will be there because what happens is the capsule will be now getting enlarged. There will be leaking into the sinusoidal spaces, and the sluggish circulation will provide some amount of hypoxia. So all will contribute to the damage of the liver. So the liver will be tender because of the hepatitis. So then laboratory evidence, as we said, more than 10% increase in the hematocrit from blood pressure, from the baseline, platelets less than 100,000, elevation in the AST and ALT, but AST is the one which would elevate first, and it would be very high compared to the ALT, and ALT will follow slowly later on because ALT is much more liver specific. But here AST can mainly come from the liver in dengue fever, but in additionally they will also can come from the muscle breakdown as well. So that is how you will do the basic investigations. Now someone wanted explanation about the blood pressure. So blood pressure is that you keep the patient supine and then you check the blood pressure. You don't remove the blood pressure cuff. Then once you have done that, you make the person sit on the bed. And when you sit on the bed, that his legs, he should be sitting just like in a chair, where the trunk will be vertically, then his thighs horizontally, then again the legs will be hanging from the side of the bed as vertically. So you can see that hip is bent at 90 degrees and then the knee is bent at 90 degrees. So in that way, when the person sits like that, he will be getting the legs out of the bed and collecting any fluid or any blood in the venous pool. So that will show, because that can't happen whenever they sit up even or stand up. They cannot have big significant changes in the blood pressure. But this is how you check for postural hypertension when a child is who is actually bed bound more or less. So you have to get them, make them sit on the bed with legs hanging from the side of the bed. So I hope that is clear for you all when it measuring the blood pressure. Of course, when you come to the ward, you have to make sure that you practice this and see for real how it is happening. So AST, I told you, is elevated more than the ALT because AST has several sources, and AST is the first thing which comes out of the cytoplasm, whereas ALT actually is a mitochondrial bound enzyme which takes a little while to come out of the cell. So the damage, how it happens, that will be there with the AST going up much more higher than the ALT. Then temperature measurement. So QHT, it is quarter hour temperature, that is 4-hourly temperature measurement. It is not quarterly hour temperature, that is not every 15 minutes. Then the vital parameter. So when a child comes and if you suspect dengue, now still has not gone into critical phase, but it is in the febrile phase, still you have to monitor. You can't wait till they go into critical phase, because when you do the proper monitoring during febrile phase, you are bound to pick any patient with dengue or pending critical phase. So it is easy to identify them on time. So you do the pulse rate, blood pressure, then respiratory rate, capillary refill time at 4-hourly intervals, and then you document and see the pattern. So whenever you make a document, you have to compare with the previous records and see whether this has deviated for worse. And then of course, you have to take action. Or if you've seen that there is a downward trend, it is not significantly dropped, it could be always advisable that you come after 2 hours or 1 hour and do a recheck. Because if the person goes into shock, then of course, it is quite easy to take. So definitely you have to maintain input-output chart. Even at home front sometimes, if the parents are educated enough, if they have the understanding, if you have given the proper advice, you can do that. Because measuring jars are fairly free, available from pharmacies. They are not very costly also. So you can tell them to use that for intake as well as separate one for output measurement. And then, because especially if the platelet count is 200, 300,000, the child is well taking orally, and there is no never guarantee that there is all will end up with critical phase or dengue hemorrhagic fever. You can manage them at home with this input out. So even the output, you can give the target. You can tell them, okay, every 3 hours or every 4 hours, you have to get the child to pass urine. And then you give the target. Okay, if the child is 10 kilos, you know it should be 40 milliliters at the end of every 4 hours. So if you tell them the urine output is less than 40 milliliters, then it is a warning sign and come to a hospital. So that way you can ease up most of this management and get them on time to the hospital while you don't really overcrowd the hospital as well. So full blood count doing twice daily is more than enough. Unless it is really, really critical, it has come to something like less than 15,000 or 10,000 sometimes. But twice daily is more than enough. Hematocrit also again twice daily is enough unless there is evidence of leaking and shock. Then you may have to do it before and probably afterwards also, just to make sure that your management has worked. But of course, I don't recommend to do very much of finger prick PCVs, because that will also be ultimately a source of infection at the tip of the fingers. So if it is not necessary, you should not be doing, because sometimes the practice what happens is, without doing a clinical examination, by mechanical manner, you keep on doing the PCV. So that type of a thing would also cause long-term problems or prolong the hospital stay, because we have seen people ultimately getting infected at the from the fingertip puncture sites. So you have to be careful about or mindful about that as well. So then critical phase, we said that the platelet has gone down, PCV has gone up by about 20%. Then there can be bleeding, organ failure, even death if we don't manage it properly. Usually it lasts for 24 hours, but of course it can go beyond that. And we expect the maximum leak to occur around 24 hours. So although it is said 48 hours, these are only guiding values, and there is no hard and fast rule to say exactly at 24 hours it maximally leak, and now we are in 30 hours, it is not leaking anymore. There is nothing like that. These are all which we can use ourselves easy. Any issues? Right. So then what happens, as I told you also, not but you can intensify the monitoring to about also at a more frequent interval. So now when you are hemodynamically, you have a little bit of a doubt, you can, or not even doubt, all patients who are going on to the 4th day onwards should have a thorough evaluation during your clinical rounds. So the mental state has to be looked into, where it is clear or lucid. Then in compensated shock, they are of course more or less still their mental state is fairly okay, but the peripherals will be the compensated place or where there have been compromised places. And then if there is hypovolemic shock, then because there is no fluid inside the body to redistribute, they are fluid depleted, they will have restless and combative and sometimes even comatose state. So capillary refilling time, very brisk, very prolonged, and very poor. You have to wait for 3, 4, 5 seconds to see a response. Peripheral extremities will be warm and pink in a normal person. Then pending, it will be slightly cold, whereas in hypovolemic shock, it will be very cold and clammy. And if you exert pressure, again, it's something like capillary refilling time. The refill will take a long time. Peripheral pulses good, weak, thready, and almost difficult to feel in hypotensive shock state. Whereas heart rate, of course, will be severe tachycardia. And with time, with the acidosis setting, it may even go into bradycardia as we discussed yesterday. The background of metabolic acidosis. Then if the pulse pressure is less than, actually we take about 25 to make sure that we are not losing very much. 25 to or 30 to 20, you can take it as more of a compromise and be on the alert. And less than 20, you can take it as hypotensive. Respiration normal, tachypnea and metabolic acidosis. So there will be not much of lung signs, but there will be rapid short breaths taken by the person. Now, when the person enters into the critical phase, we have to make sure that we give the correct amount of fluid. We should not give too much of fluid, nor we should give less fluid also. So just to make sure that we are not given too much of fluid, we have this concept of what is called the quota system, where we will say, okay, now he has started the critical phase roughly at this particular time. So for the next 48 hours, it's likely to go on, but we have to give not too much of fluid. That to guide us to say, okay, this much now you have given, you quota system. So the quota is plus fluid requirement. You can see yesterday we discussed that the maintenance, how do you calculate based on the body weight? First is 10 kilos per 10, then the next 10, 50, and you add the 1000 from here. And if it is going to the third, 10 kilos above, then you 20 per kilo with another 1500 because of the first 20 kilo weight. And then you make again another 5% deficit, that is 50 ml per kilo total body weight, and give it. So this is total together, that is safer to be administered during the next 48 hours. But that does not mean that you have to give this all together, because sometimes, some time ago, people had the practice that they calculate this quota, divide by 48, and then say, okay, infuse this much of per hour. That is totally wrong. What you have to give, you should not give too much of fluid, even if you have the leverage. Similarly, you should not give too little of fluid, because you have to make sure that your circulation is not compromised. That is, you have given adequate amount of fluid to the person, as well as to maintain the peripheral circulation, that is adequate pulse more than 30, urine output more than 1 ml per kilo per hour, as well as a reasonable pulse rate, giving leverage for the fever. That is something maybe around 100, 110 maximum should be the allowable, but below that you should have, and especially when the temperature is controlled, it should be less than 100. And that way you have to maintain. So if there is not enough fluid, where any of these parameters, where there is tachycardia, pulse pressure is low, then there is capillary filling time is low, or peripheries are cold, then you may have to increase the fluid, where you can give as a bolus or what is called a half bolus. So that way we can give the fluid. So addition to that, you also have to make sure that we are not causing hypoglycemia or hyperglycemia, and then electrolytes and acid-base balance. Especially if a child is very restless or sometimes very sleepy, you have to look at the sodium levels, because sodium is sometimes becomes hyponatremic, and that is one of the main features that will keep the child on a CNS depression. That is mainly because I think where the fluid is not getting circulated properly, because the vascularity is getting compromised. So you have to then correct the electrolytes, sodium, with 3% sodium chloride, you can use it, and then make sure that the electrolytes are increased. So roughly about 3 to 5 millimoles or milliliters of 3% sodium chloride per kilogram given over 1 hour would correct that, as well as, because it is a hyposmolar solution, there will be correction of the circulation also to some extent, because that will help to bring back some of the extravasated fluid, because now we are making a 3% sodium chloride in the intravascular compartment. Then we have to look for acidosis. So if the child is having rapid short breaths and there is no lung signs, as we discussed yesterday, we can do blood gas and see, and may need bicarbonate, but most of the time when you correct the circulation, and you know acidosis happens because the circulation is compromised at cellular level. So there is no way to get rid of its lactic acid as well as the carbon dioxide. So that will increase and causes acidosis. The bleeding tendency you have to look for, and you have to always keep blood cross-match. Then hypocalcemia is another big problem which we come across in these children, because they keep on, because you know when they leak albumin also. And with the albumin leakage, the calcium will also leak out of the blood vessels. So as a result, they become hypocalcemic, which cause again increase to the morbidity, for contribute to the bleeding, as well as it can contribute to other cellular function. So that's why in our unit, we of course give regular calcium supplementation whenever we suspect a case of dengue fever. Then sugar during critical phase, you have to look in. So these are some of the other complications which you have to be now. Electrolytes you are not expected to do daily. Calcium even you are not expected to do daily, but you can do those two maybe once a day, unless it is very low, or if you have had to correct action, then of course you have to do it twice a day to make sure that you have corrected the thing. But otherwise, once daily when it is in the critical phase should be enough. Then acidosis, we don't check blood gases in each and every child unless it is clinically indicated. So that is how. So the management is that for looking for these complications, not waiting them to happen, but to correct them before they go into a little bit of severe state. So now we have this compensated shock. So you come, you see the patient, the urine output is maybe around 0.7, 0.8 ml per kilo per hour, not below 0.5. And then the heart rate is 120, pulse pressure is about 25, 26. Peripheral capillary fill time about 2 to 3 seconds. Then of course you don't weight, you have to correct it. So you can give actually a sodium chloride bolus. Now the recommendation is to give 10 ml per kilo per hour. But as I told you early, you try to manage these patients as much as low amounts of fluid with low amounts of fluid rather than giving large amounts of fluid. Now the whole reason is you have to maintain the vitals. So if you give too much of fluid, you increase the hydrostatic pressure inside the blood vessels. They are already leaked and you are just letting them go again. So more you give, it will cause more edema in the peripheral tissues. So that will cause again certain amount of damage to, especially for organs, especially the liver, because liver does not have a internal vasculature to take, but it takes to the sinusoids. So if you cause edema in the hepatocytes, and then the edema will cause sluggishness of the circulation, and that will lead to hypovolemia, hypoperfusion, leading to tissue hypoxia, causing liver damage. And liver damage, more than even the kidney damage, is very, very bad sign when it comes to the management of dengue infection. So if the liver gets damaged, especially in the early stages of the infection, it is quite difficult to correct it. And most of the mortality, what we have experienced, is due to the early liver damage. So you have to make sure that the liver is not damaged and you have to take your action to prevent that. So that's why instead of giving 10 ml per kilo over 1 hour, what we try to do is we give 5 ml per kilo in half an hour. So at the end of half an hour, we again quickly look at the parameters, see whether they have improved. If they have not improved, we continue with the balance 5 ml per kilo over the next half an hour and complete the 10 ml. But if the things have improved and we are satisfied, then we can stop there, giving the full bolus, and then we can come to a little bit lesser amount. Maybe either you can go as 5 ml per kilo for the next 1 hour, or you can increase it to about 7 ml per kilo over 1 hour and then gradually reduce it. So the whole idea what I want you all to get is that you should not give fluid just because it is given in the guideline, but you have to make sure that you clinically assess the patient and give the minimum amount to meet the requirement, the basic requirement, that is to maintain the vital signs of the child. So that's where this half bolus concept has come in, and many units now practice this. Only thing is that after half an hour, you have to come and examine the child and then decide whether I am going to continue the balance over the next half an hour, or whether I am going to schedule the fluid at a lower rate and give over next period of time. So then after 1 hour, even if the full bolus is given, if the child has not improved, then you can repeat the sodium chloride 0.9% bolus again. You don't change the fluid, but you continue the same. So that is 10 ml per kilo first hour, no improvement. Then another 10 ml per kilo over the next 1 hour. And if after those two, you have not got improved, then you can go for a dextran bolus. So dextran also, as we discussed yesterday, it remains in the circulation for long period of time. Now, one thing what happens when you give a bolus of sodium chloride, it can escape very fast also and increase the speed of leaking. So because of that also, it may not hold the fluid in the compartment. So you hydrate them with this, and then you give a compound which will hold the water inside the circulation. That's where you give the dextran to these children. So again, the dextran also, although the guideline talks about the full bolus, again the practice what we do is we try to give a half bolus and see whether we can achieve what we have to achieve. Because again, you can remember that the per day, the amount of dextran can be given is limited. We usually give not more than 2, because the half-life is so long and it takes a long time to get cleared from the circulation. So if it does not get clear adequately, it can go and clog the microcirculation. So when it clogs the microcirculation, that is the main reason why tissues get damaged. So because of that, we try to preserve excess amount of colloids by giving a lesser amount, but achieving what we need to achieve, that is to maintain a good tissue circulation. So then if the improvement is seen, then you can gradually step down. So that's why I said, okay, you start from 10 ml and you give it for 1 hour, things improve, or half an hour. Then you can come down to about 8 or 7, usually 7. Then you can come down to 5. Like that, gradually you will come down to about 3 to 4 ml per kilo. If you can maintain everything but 2 ml per kilo per hour rate, that would be the ideal amount, provided that you have adequate urine output and good blood pressure and pulse rate. So you can give 1 to 2 colloids maximum, but you should not give too many, as I told you earlier. And then but still circulation could not be dropping, where there can be poor pulse, increased pulse rate, peripheries are cold, and then there is tachycardia, blood pressure is dropping. Then what you have to do is, you have to give a blood after doing a PCV, because PCV will drop when there is a leak. There is cellular matter is there inside the blood vessel, so that will also increase in the hematocrit. The concentration of the hemoglobin or the blood will be increased. But when there is a leak, or when there is a bleed, the blood will be going out, irrespective of its content. It does not remain inside any part. So cells as well as the plasma leaks out. Then the whole PCV will drop, because in the background you are giving crystalloids. And then if the PCV drops, then you have to give blood. Earlier, the threshold of giving blood was fairly low, that you have to wait a long time and make sure. But of course, now we do usually give blood at an earlier stage, because that will also help them the oxygen carrying capacity by giving some more red blood cells into the circulation. Because one main problem is that tissue hypoxia, which damage. So tissue hypoxia occurs because of the less circulation, and the oxygen carrying capacity could be improved with giving some amount of blood. And but what you have to make sure is that you have to make sure that the hematocrit is brought down. At least it has to be brought down into below 35 before giving, but definitely not above 40. You should give blood, because then again it will clog the circulation. It is much more thicker than even a colloid, and there will be issues. So you should not be giving transfusing blood with a high PCV, but it has to come down to a certain extent. And there are other mechanisms which we adopt. Of course, when you're in the ward, you will see. I don't want to elaborate here. Where you can dilute the blood in certain ways and give it without making a huge problem if the blood is really, really required. So those are additional things. But at your level, I think if you decide to give blood, you have to make sure that the hematocrit is reasonably low. Otherwise, you will end up with, again, other issues. So now you have tried to correct it. It has not got corrected, or the patient has now arrived with total shock, which we discussed yesterday. So this happens, usually does not happen a hypertensive shock while in the hospital. It mainly that they come to the ETU with staying, or either they have gone into a leaking phase much early in the course, or they have neglected and not taken enough fluid, and then they have come as hypertensive shock. So then you have to give 20 ml per kilo rapid bolus, and if it is not responding, even the second one you may have to give. Then if there is response, then you come down to a smaller bolus of 10 ml per kilo per hour. But again, this also you may be able to change depending on your response to the fluid boluses, because we always should remember, unnecessarily we should not be giving fluid. What we want is to maintain the blood pressure, pulse pressure, good tissue perfusion, and if that is there, don't unnecessarily give fluid in dengue fever, because as much as hypotension causes or underperfusion causes death, over infusion also causes death. That has been shown clearly in this country in previous mortality reports, that 50% of the deaths sometimes are due to over infusion of fluid. So you should not give any amount of fluid because it is not that easy to get out the fluid later on. It has to come again through the normal physiological processes. So in that process, it will lead to a lot of difficult state. So again, as I said, you try to give the minimum amount of fluid, but try to achieve the maximum clinical benefit. And then you rapidly come down in the levels based on the response, and then try to settle maybe around 2 to 3 milliliters per kilogram per hour rate. So if no response, the PCV is rising, then repeat 1 to 2 colloids as we discussed earlier in compensated shock. And if the SCT is dropping, no improvement in shock, give blood transfusion at 10 ml per kilo per hour. 10 ml per kilo, usually over 2 to 4 hour period you can give based on the size of the child. So if things are okay, then 24 hours after admission, examination will relieve a cold line little above the ankle with capillary refill time 3 seconds. So you can see now things are again. This is the typical picture that you will see in a ward management patient who had been doing okay in the initial phase. So slight reduction in air entry, right lower zone, which gives the feeling of that there is now leakage, and respiratory rate is still not compromised, because when the pleural effusion increases, the tachypnea will set in because he has to compensate to loss of lung volume. And then the abdomen soft, but there will be tender hepatomegaly, and there can be tender epigastrium because of the edema and the acidosis, or sorry, the acidic gastropathy, where there is a certain amount of damage happening into the outer layers of the gastric epithelium, giving rise to the, especially because of the edema which happens in the submucosal region, that the epigastric tenderness occurs, which we call as gastropathy, and then it can further lead to bleed. So if there is severe tenderness, that means there can be imminent bleeding or already bleeding occur. So if you do the blood counts, you will see that the WBC is now dropping, hemoglobin going up with the PCT, HCT going up, and then the platelets will be at a lower level. So if you see a patient with shock, then the shock can be a narrow pulse, which is again a compensated shock, or it can be a profound shock where the BP and pulse is almost unrecordable, and then the child is in more of a peripheral circulation totally compromised, even the cerebral circulation is compromised. So if it is a compensated shock, you adjust the rate according to the HCT pulse rate, where we said we will give 10 ml per kilo. There is narrow pulse pressure. So 1 to 2 boluses can be given. If it responds, then you will come down. So you start the 10 ml per kilo bolus, and then 1 or 2 boluses, things will improve. And if it is a profound shock, you give 20 ml per kilo bolus, and then you see how it responds. If it is responding, then you come down to 10 ml per kilo bolus, and then you are guided by the monitoring of the patient. Now in critical phase, of course, you have to monitor every hour the parameters. And if you are doing if you are in one of these shock stages, then of course half an hour you have to monitor, because to make sure that the management is working. Because I told you that you can give a half bolus also, that is in half an hour, and that means you have next half an hour, even earlier than that. So you have to act accordingly. So in any of the shock stages, you have to intensify the monitoring to half an hour, but in the critical phase, you have to monitor every hour. So if this is you continue, no response, you have to give again another 10 ml or very poor perfusion, unrecordable, no improvement at all. Even 20 ml bolus may have to be given. Now in this again, the compensated person where you have given the 10 ml bolus, it has not responded, then of course you have to go here where you repeat a second 10 ml bolus and then you see whether there is a response or no response. If there is a response, then you gradually again adjust the fluid coming down to maybe 7, 5, 4, 3 like that. Maybe you also give it not every hour, you may go for about 2 hours like that, and then you can gradually come down. But if there is no response, then of course you have to do the PCV immediately, see what has happened. If the PCV is high, then you repeat the colloid because still it is leaking a lot to hold on to the circulation. But if the PCV has dropped, especially from the pre-shock state, then of course definitely it's a bleed. So you have to give a blood transfusion immediately. So this is actually the flow chart that you have to follow more or less in the management of a shock state, whether it is compensated or whether it is an uncompensated shock. So then usually after about 24-30 hours, things will begin to improve. And I told you that the WBC begins to rise is one of the earliest signs. And there will be now circulation is getting overloaded. There is a increased venous return happening. Because of that, there will be a delay in the closure of the pulmonary and the aortic valves. So as a result of, there will be a splitting of the second heart sound. So if you hear this split, then that is of course a sign of relief for you, where things seems to be that at least the leak has now stopped. But sometimes it will be difficult if there had been a bad tissue damage that has occurred in the liver or the kidney. But overall, at least the leaking has stopped to a great extent when the split begins to occur in the heart, because now the fluid is returning and there is a mismatch between the right heart and the left heart output. So usually by the 6th day, blood pressure will become stable and the urine output improves. Sometimes they will now go into a diuretic phase. And there is no evidence of new bleeds. PCV platelet begins to improve. And if you do the dengue serology after completion of 5 days, you will get them positive as well. Now, initially I told you that the critical phase have to be managed actively. But having said that, even in the early recovery phase, you have to have a little bit of active management, because now this fluid is coming out and the kidneys were geared to preserve the fluid. Now, you know, when there is hypovolemia with all the other hormones in the body, they will be trying to conserve water. So the antidiuretic effect, the urinary excretory effect is reduced. But when now those hormones will take some time to go out of the circulation. So they will be there exerting action. But the fluid will come into the circulation almost at the same rate that they were leaking out. So it's very rapidly it happens. Then what will happen is that their circulation will get overloaded. And that will give a undue strain on the heart. So because of that, what you can do is, if you're quite sure that we have come out of the leaking and now there is increase in the blood pressure, pulse pressure is improving, and the tachycardia is improving, you can start oral furosemide. Some people, of course, give IV furosemide, but that has to be very carefully done. But oral furosemide, 1 milligram or 0.5 milligram per kilogram, you can give actively, starting from the phase where you have seen that the child is now beginning to improve. But again, you can't forget the patient. You have to make sure that hourly you monitor the the child, and the patient is now again going into hypovolemic state. But of course, active management of the early recovery phase will help quick recovery, because that will help to pull the fluid out, especially when you pull fluid out from the lungs or the pleural cavity. It helps the lungs to expand, and that will help to excrete any collections which will otherwise could get infected, and secondary pneumonias could occur. So all that will be helpful. And then the liver also, the edema will come down, so that will improve the perfusion. And the liver, you all know, if it is corrected quickly, there will be quick recovery of the liver. Otherwise, it will go on for a long time, and there may be big damages. So that is where the liver can also be saved and improve the morbidity. So active management is also something you should remember. And usually by about 6 days plus, you will be able to send, or usually 48 hours after last bout of temperature, they are more or less fit to go home. But as a policy, we don't send them home unless their platelet count is more than 50,000. But sometimes it may come and take a little longer. So if it is something about 40,000, and if we can see, okay, 2 or 3 counts have always kept upward trend, then of course, there is no reason why it will drop. Even the platelet count has not reached 50,000, we tend to discharge them. So in the recovery phase, acute phase usually lasts for about 48 hours. Usually, that is what you have to remember. During recovery phase, fluid re-enters the circulation, and actively remove fluid is what is one of the important things. Giving fusimide 0.5 to 1 milligram orally is quite safe, and it takes a little longer also to act. So then you will not go into unnecessary difficult situations. So you can correct the or remove the excess fluid quickly. So antibody testing, don't do before 5 days. Notification is very important. Notification on day 1 itself you have to do whenever you suspect. And antigen testing, as I discussed earlier also, sometimes people tend to do it, but of course, as I told you, you have to make sure that this is not a 100% foolproof test. It depends again based on the viral load, and viral load can take a little while to develop. So that's why I always advise, don't do it in first 24 hours, and then sometimes don't do it after 48 hours, because if the viral antigens have got cleared, then of course you will come again. If you do on 3rd day of illness, you will come with a false negative NS1 antigen. So because of that, you should not be depending on this, but on cases where you highly suspect, and you can decide, especially if the child is very, very ill, then you may have to, and especially parental anxiety is very high. Then of course, and you are not quite sure whether they will do the correct job at home, you can do the antigen and make a case for admitting them. But of course, I don't think a routine place is there, because the management will not depend whether it's dengue or not, because you don't have any medication per se to give for this. So you can see how this antigen changes. So that's why I have put 2 bars, 24 to 48 hour period. And then afterwards, so this is actually overall thing. You can see even up to 8 days, people have shown that there is antigen level. But of course, these can vary. So some may have a thing like that falling down early in the course. So you never know. Because of that, to make sure that your yield is good, you try to concentrate on this second 24 hours. Then you can see if you do quite early, you may not pick everything. And then especially if you do it here, you will say, okay, it is a primary infection because only IgM, but you do it a little later. So that's why after 5 days, usually on the 6th day of pricking, you can do it. So then also you can see that you have, now I was talking about to keep the pricks into the minimum, because as much as you are giving fluid, you should also make sure that you don't have other morbidities. So to make sure that we do less amount of pricks. We put and we know that most of the cases when they go into dengue hemorrhagic fever or dengue hemorrhagic critical phase, or even in the late stages of the febrile phase, you may have to do blood investigations twice a day. So pricking a child twice a day, the problems are it is painful. Number two, you will thrombose the vessels and it will take at least another 3 to 4 days to get that site clear. So you will run out of places to take blood. And then the other thing is sometimes it can get infected and then cause problems. So because of that, we keep one cannula in situ for drawing blood. You don't wash that cannula. You can take the blood from that, and it has shown that it does not affect the measurement of parameter, because sometimes some people think that it can affect the platelet count, but quite clearly we have seen that it has never affected the platelet count. And then also we tried, then you have one other cannula to sort of give the IV fluid. So that's also the other thing is, although we said that you have to give IV fluids, it is not mandatory to give IV fluids. Most of the cases, if the parents are vigilant, you can give them as oral feeds. Now, especially during the febrile phase, you have to give the fluids. And in that case, now I told you to give an hourly rate. Now, usually we give 2 milliliters per kilogram per hour. When we are giving 2 milliliters per kilogram per hour, we can easily give it with the IV fluid, where you can set the infusion pump and but the problem is, when you use peripheral lines, it's always you are introducing infection to these lines, and the life span of the cannula will also be shortened. So if the child is not vomiting, child is old enough, can take orally, you can give fluids every hour. So you tell them, okay, the 2 ml per kilo. If the child is 20 kilos, you can say, okay, give 40 to 40 ml per hour. So you start at the top of the hour, then throughout the hour, tell them to take sips and finish it off before the end of the hour. Then, of course, what happens is if the child is sleeping, because sleep is also something very important for recovery of illness, as we now discuss, rest is important. You tell them to continue, but not to wake the child up. But the child should be woken up once in 3 hours to make sure that the urine output is maintained, because that is a crucial thing, and you should not go for hours and hours without measuring the urine. So once at the end of 3 hours, you tell them to wake the child up and then pass urine, see whether the urine is okay. And now for 3 hours, if the child has missed 340 ml, you tell them, okay, over the next half an hour or so, try to give this 120 ml additionally. So that way you can go on giving the adequate amount of fluid, correctly measure the urine, as well as provide the rest to the child. So that is how we overcome the oral thing at the times the child is sleeping. So then, of course, when it comes to the critical phase, you may have to have a background IV fluid going on most of the time. But of course, again, if it is older child or adolescent and quite compliant, no nauseation, no vomiting, sometimes we can manage, especially the second half of the critical stage with oral fluids. No need to always give IV fluids, especially during daytime when the staff is also there and the parent and the bystander is away. So that is how you usually maintain the management in dengue fever. So I will take up these questions. If there is anything, either verbally you can ask or you can type and send quickly. So the BP I explained, AST, ALT I told you. So how you maintain input-output chart is, you usually start now. Whenever they come, you start initially. But if you begin from the day in the morning, we'll say 6 a.m. in the morning you start, you try to give everything, you record everything that has been taken in. And then also everything that has been output, mainly it will be the urine output. If there is any vomiting significant, you make a note out of that. If there is any diarrheal stools, you make a note out of that, and then you keep on recording the input as well as the output. So then what happens is when you come to the following day morning, you have to see what had been the balance. What is the input? What is the output? So the input may be 1000 milliliters. The output may be 700 milliliters. So that means there is 300 milliliter deficit. So of course you have to bear in mind what had been the insensible losses. So that of course can be compensated to the insensible loss. But of course you will take at that without taking that into your mind into the chart, but you put it as 300 milliliters positive balance because there had been retention of this 300 milliliters in the body. Now when it comes to the second day, you have to make sure that you take this 300 plus inside the body. So you start with the brought forward balance 300 plus, and then you go on same thing, and for the next second 24 hours, okay, now the leaking has set in, you have given a lot of fluid, urine output has been only marginal, there will be 1000 positive balance. Now you have to make sure that you have to remember that there had been 300 balance in the previous day also. So you have to write it as 300 plus this, and the grand balance is 1300. It is not 1000 because you can't forget, because now your management is you have to bear in mind this. I have put more excess of 1.3 liters into the body of this child. It may not be exactly 1.3 because the insensible loss you have not calculated very much. But of course, again, when they are resting and mostly when they are in a air-conditioned room, the insensible loss will be less also. So we don't really take that into discussion, but of course you have to make sure that you take the brought forward. Then when you go to the third day, at the end of third day, okay, input will be 1000, output will be 1200. So that means he has passed 200x from what he had retained early. So then the grand balance come down from 1001 on the third day. So then you have to remember, okay, yesterday I had put 300 in his body, but today I have managed to get 200 out. So now it is only another 1100 positive that the child is remained. So you have to remember not only the daily balance, but from the time you began to maintain the balance chart, what is the overall balance, whether it's a positive or whether it's a negative inside the body is what you have to make sure, remember, and act for that, because that is where you have to decide, okay, now this person has excess fluid, I must somehow or another take it out before I send him home, and that point you can give some furosemide. Sometimes the diastolic rise because of the high response to the hypovolemia, because the venous tone goes up, and that will try to reduce the venous pooling, and because of that the tone in the blood vessels or the venous tone, arterial tone, because of that, because venous tone will increase the fluid coming back or reduce the pooling of blood, and then the arterial tone will increase, because of that the diastole will come down, will go up. So that is systolic pressure will come down, will contribute to the narrowing of the pulse pressure. So that is actually basic calculation must be done. Yeah, now that here we don't calculate the fluid. Now that is actually, you have to remember. Now the 48-hour business, the fluid quota is not to give that. Now you have to remember, clearly understand this. That's why I said this is a quota which you mark and say, okay, for this child, okay, we'll say a 10 kilo weighing baby. So for the requirement will be for 24 hours is 1000. Now for the 50% or the 5% deficit, it is 500. So 1500 is allowed for this child to be given over the next 48 hours. But if we can manage this child giving only 500 milliliters, that is quite okay. So we don't have to give all these 1500. So that is what you have to remember quite clearly. Now in diarrhea, of course, the person has lost fluid. And then we have to replace that. And they have gone into either no signs of dehydration with developing diarrhea, and we correct them into either with some dehydration or severe dehydration. So that means they have lost the quantum of water from the body. In dengue fever, they have not lost water from the body as a whole, but they have lost water from their vasculature going out. So the degree of vasculature's ability to compensate and maintain the blood pressure is what we have to judge. If they can't maintain the blood pressure, then we have to give fluid. If we can maintain the blood pressure, pulse rate, tissue perfusion, although there is leaking, we still don't have to give large amounts of fluid because the body is now managing quite okay. Because if you give too much of fluid, as I told you, it increases the hydrostatic pressure, and the hydrostatic pressure will make fluid go out of the circulation. So you are potentiating actually leak by giving too much of fluid. So you just try to give the minimum amount of fluid, which will go along the blood vessels, provide the necessary amount of nutrients, oxygen to the tissue, take away the lactic acid, other metabolites, carbon dioxide away from the tissue. That is all. So once you have given, now we calculated this 1500. At the end of 24 hours, we have given only 500. So we can be happy and say, okay, we have given only 30% of the quota. I have another 70% to be given. But in the same way, if you have given 1200 milliliters, then of course you will say, okay, my good, by 24 hours I have given 80%. I have to be much more careful than this. I can't be giving too much of fluid. But if you have to keep the patient alive, you sometimes disregard this, and you may have to give by second day. If they are still keep on heavily leaking, you may give, even if you have said 1500, you may go and end up with 2 liters. So the whole idea of this calculation is just to tell you, okay, this much of fluid you are being given, try to manage within this. If you can, you save as much as possible. If you are not so, then you try to borrow some more. It is just like that you have given a monthly salary or allowance and go out and spend. That does not mean you have to spend the entire allowance. You can save something. If you have not enough, you have to make sure that you have to buy certain things. You may then take a loan and try to compensate the balance. So it is similar to that. It does not mean that you have to infuse all this fluid. It does not mean that you are given only this. After 30 hours, it is over. For the next 18 hours, you are not given any fluid. You can't wait. It's not the case. If you have to keep the patient alive, you have to give the fluid, you have to give that. But you try to manage within the quota to use it more economically rather than that. I hope the person has got an idea about this. This is not a volume to be transfused. That's why I categorically said earlier, sometimes people divide this volume by 48 and then gave it per hour. It is not the case. It is just only a safety value. This is it. See whether you can manage. If you can't, we will give more. But if you can, that is much more better management style. That is the main thing you have to remember there. Is there any change in the potassium level? Usually no, because the potassium is there inside the body. It is not in diarrhea. You are losing the potassium in your stools. Here we are not losing anything from the body unless we are passing it from the urine. So hypovolemia, because anyway it is an intracellular thing, and because of that the potassium drop is not very significant. But of course it can drop by about a millimole or a 1.5 millimole, but that is insignificant for the function. But sodium drop is much more significant, so you have to correct it. Is there a way to assess hypocalcemia? Hypocalcemia, of course, is we are looking at the tetany features, but that is of course much more delay. Otherwise, there is nothing to say, okay, we are now in a state of hypocalcemia. It does not really stay, so you have to do the levels to see the small drop in the biochemical range. the patient responds well with the first bolus. Do we stop the fluid bolus? Then what is the next? So that's why I said, even the first bolus, halfway we will try to stop and see. Because our whole idea is to give minimum amount of fluid and to create minimum amount of unnecessary morbidity, but to make sure that we have maintained the vital parameters. So that is where you try to give. So even at the halfway of the bolus, we stop and then we try to see if we are okay, we calm down prudently the amount of fluid we give. If not, we continue, and if we have not achieved what we want to achieve, we give more. So the second bolus can be given, even a third bolus, fourth bolus. Usually the third would be a colloid, can be also given, and failing that, even blood can be given. NS1 antigen test is not done regularly. When asked, we got to know that there is a less use in doing on the third or fourth day of low sensitivity. Sir, can you please explain? I hope I explained in this, because you are looking at virus antigen. So the virus come into the body. You have to give some time for the virus to multiply and produce the antigen, and then antibodies will be developed. And if it is a secondary infection, already you have the memory. So the antibody formation will be little rapid. So then, of course, quickly the antibodies will come into the circulation, and they will scavenge the antigen and bring the antigen level to an undetectable level. So anything, so that's why I say it is not a very good test. If it is positive, it is positive. But if it is negative, it does not 100% rule out dengue fever. Even on second day of illness, because this person may be a slow antigen producer, taking a little longer to produce. So like that, it could be a misleading thing. So that still it may not be negative. You have investigations and clinical examination. What are the preferred oral fluids during febrile phase? So just to give a sodium containing, salt containing fluid, because if you give plain water, it will always go out of the circulation. If you give dextrose containing water, again the dextrose will be quickly used and it will become plain water. So you try to give a sodium containing fluid, where you can give either ORS, or you can give them any fruit juice. You can tell them add a little bit of salt, as well as you add a little bit of sugar, because you can provide a little bit of palatability as well as some amount of calories, and that will help them to retain the fluid. You can even recommend to give kanji, but of course you have to bear in mind a little bit, because it sometimes makes a brown color. If you use white rice, it is okay. Otherwise, the brown color may lead a little bit of problem if there is a gastric bleed. Paracetamol 10 to 15, is it per day or per dose, right? So that can be repeated once in 6 hours. So 10 milligram per kilogram per dose, and every time, so the maximum dose is 60 milligram per kilogram per day. And you can give 4 doses. Usually that's how it comes to the 4 doses. And then if you are giving at 4 hours, or 5 hours for some reason or another, then the next dose should be delayed by that amount of time. So if you have given the second dose after end of 4 hours because of high temperature, then the third dose should be given only 8 hours after the second dose, because you have to catch that 2 hours from somewhere later. Do we have to subtract the positive deficit of febrile phase when calculated fluid quota? Well, febrile phase does not come into the calculation of quota. Quota comes only into the fluid requirement or fluid safety net for the critical phase. It is nothing to do with the previous time, because there is no leak. So the fluid which we give will come out through the physiological routes, that is urine, sweat, as well as breath. But once it goes into the critical phase, you are leaking fluid inside your body. And we don't want to overload the person. So the whole basis of giving this 48-hour quota is to make sure that we do not overload. From time to time, it reminds us, okay, this much of percentage you have used, because you can't just use your normal recommended daily allowance. Do not calculate fluid amount using maintenance. Then which rate should we give the fluid in critical phase? So the critical phase is balance. Actually, there is no rate. So that's why I say the minimum we try to give is 2 milliliters per kilogram. And if we can maintain the parameters, that is the urine output, blood pressure, pulse rate, peripheral circulation with capillary refilling time, that is all what we try to achieve. We are not trying to give a certain volume. Okay, this child is recommended 1500 milliliters per day. We want to give that. No, we are not bound to do that, because the whole idea is to keep the vital parameters going on. So that denotes the minimum amount of fluid which is required for the circulation to go. But if we just prescribe based on the normal value of the person or the requirement of the person, we will definitely overperfuse the child. And then that will lead to more edema fluid formation. More edema fluid formation means it is affecting the peripheral circulation to a great extent by putting pressure on the capillaries. So that's why we try to maintain a minimum of 2 ml per kilo, either orally or IV. And then if it is not enough, we will increase to achieve the desired parameters for blood pressure, urine output, then capillary refilling time and the pulse rate. So that is the whole idea. If we can manage the patient with less fluid volume in the critical phase, how do we decide the initial amount to give to this patient? So that's why I said the 2 milliliter per kilogram per day is the usual idea. But sometimes if it is not matching the maintenance, you may have to go for about 3 ml per kilo. But the whole idea is that, I think you have got it, is that we try to maintain with the minimum amount of fluid. So if the urine output is good, if the peripheries are good, periphery circulation is good, that means he's having enough amount of fluid. Because one other thing what we can't measure here is the insensible losses, because especially if they are in a cool room where their losses are minimum, so you will conserve some amount of fluid also there. So your requirement will also come down. So that way you have to maintain your requirement. The whole presentation will be uploaded. Dehydration lectures in calculation. Yeah, the normal calculation which we do always is for 24 hours. Now in dengue, what you have to remember, this calculation what I gave is not a calculation to be infused. It is a calculation of safety. So that is for a 48-hour, not the requirement, but it is the amount we should be trying to manipulate and give with to prevent us over giving fluid. So over transfusion is the killer, as by now you should understand in dengue in 50% of the cases. So that is what we try to maintain. Now 80 to 50 blood pressure is considerable, because what happens is if it is a large child, the systolic blood pressure 80 is not enough. So then at 30, you have to make sure. Then again, another thing that you have to make sure is that your measuring equipment is also quite up to date. Sometimes people use monitoring devices which can give rise to problems. So you have to periodically test them, see whether they are well calibrated. So no sooner you have a doubt, always try to use the mercury manual meter and then measure the blood pressure. So that's why if the patient improves with the half bolus, then you come down in the fluid. So the half bolus is, that is 10 ml per kilo per hour. When you give it as in half hour, it becomes actually 5 ml per kilo per in half an hour. So that volume, once you have given it, then of course what will happen is things have improved. Then you thing, then you consider, okay, I have given us enough bolus. Now the basal parameters have improved. And now doing according to the response that I have received. So what now you have received at the end of in dengue management, what I achieved the maximum amount of homeostasis or the vital parameters. Giving blood to an already bleeding patient causes problem due to bleeding at organ level. Yes, you should not be giving over perfusing and over excess amounts, because ultimately what will happen is you will create a large tamponade defect depending on the place where it bleeds, and that blood itself can be a killer. So you are trying to give the blood in order to try to maintain the certain amount of compensate the losses and improve the circulation, improve the oxygen carrying capacity, while you have to make sure that you don't give too much of blood where it will keep on oozing from the place and aggravate. So that's why I said anything, you have to do certain things, but you should not be doing things in excess. In dengue, you have to give fluid, but you should not be giving unnecessary excess amount of fluid. So that is what happens. So most of the time, so that's why I said dengue management, the key is monitoring. It is not the fluid. You can't prescribe fluid and come after 6 hours and say, patient has died. It is every half an hour, 1 hour, depending on the stage of the illness, you can do it. And it is very rewarding that you can cure 99% of these. So the bad ones are the ones who really go into liver failure in the early stage. That may be genetic also, because sometimes the virus can directly go and damage the liver. But apart from that, no child should be dying of unable to compromise or due to compromised vascular circulation, because we should be able to spot that and correct it then and there. So that is the key in the management of dengue. How to manage the fluid in the breastfed baby? That is, of course, you try to again manipulate that. You have to be very, very careful. You take the breastfeeding is providing the maintenance, and then you try to give small boluses or very small IV fluids, about 1 ml or maximum 2 ml most of the time, and then manage. So that's the whole thing, is that you have to keep an eye always on these children. You can't write the management and after 6 hours come and look. So that is the important thing. Is there a way to prevent postural drop of blood pressure? The prevention of postural drop of blood pressure is giving the adequate fluid volume. So you have to give sometimes more colloid. Even after the first crystalloid, still the postural drop is there, but the other parameters have improved. You may give a half bolus of crystalloid in order to prevent the postural drop. What is the duration to give maintenance fluid when it comes to diarrhea? Is it 24? No, maintenance fluid, what do you mean? You have to give maintenance fluid every person. Every living being should be having the maintenance fluid, no? Whether it's diarrhea or not, no. You and I also have to take the maintenance fluid. So, I don't know, I'm not quite clear about this question, because the maintenance fluid is any healthy person should be taking that. Any ill person should be taking that. Any losses of fluid in addition to the maintenance should be taken to replace that. And the replacement depends on the way they have lost. Diarrhea, they have lost from the body, so you have to give it into the body. In dengue, they have lost inside the body, which is going to come back, and you have to bear that in mind and then do the necessary. So that's why in dengue, you should not be giving too much of fluid, because he is not losing from the body. If a child coming on the 4th day already is critical phase with the pleural effusion, do we need to consider the fluid given? We have to actually consider, but we will not have much of available information about how much they are given at home during the initial phase of the critical phase. So, but given leverage, so that's why actually what is matter is how much of fluid that they have not taken, how much of fluid we are going to give and manage this time. So that's why if you keep your policy, I will be giving the smallest amount of fluid, then you have to, because at the end of the day, whole idea is to keep the patient alive. For that, you have to give a certain quantum of fluid. So that quantum of fluid should be given with close monitoring, not that you write today and come 6 hours, 12 hours later and see what has happened. No, that's why every hour, sometimes you have to change it half an hourly in the critical phase and increase or decrease the fluid volume. And that is the key to success in the management of dengue fever. If a patient goes into shock, the fluid bolus we give we have to subtract it from the 48-hour quota. Yes, whatever you have given during this 48 hours is from the quota that was given to you. So you are within that. So that's why at the quota is actually just to keep it on the board written, okay, you are given this much, play around with that. So as I told you, your monthly allowance, you are given an allowance, within that allowance you have to try to manage. If you can manage, it is good that you have saved something for your next month. But if you have not managed, your spend, but your all spending has been vital, that you have to anyway survive another 5 days in the month, you have to borrow the balance, whatever money, and then you have to spend it. So you have to loan it out, you have to get it out, just the same way. Your monthly allowance is not that mandatory, you have to spend it and show a zero balance. Here we are not being bound to make sure that by end of the 48th hour, okay, every drop of the fluid is finished. No, you have to keep on giving the amount which is required. So try to maintain at the minimum. And if you need any more, can't help, you have to go for that for the sake of keeping the patient alive. But it should be well spent amount of fluid, not wasted fluid inside the body, because wasting fluid inside the body leads to a lot of complications. So that is what we have to bear in mind. The irritation of critical is retrospective. How can we sure how much fluid given orally before we start the fluid quota? Initiation of critical phases. Yeah, sometimes it is retrospective. Sometimes, yeah, most of the time it is retrospective. So that's why now what we have taken in, we will not be able to 100% know. And it really not going to matter to a great extent, because this fluid will not going to stay around. And it is not going, what we are going to give is not going to depend on how much the child had already got. It is what is required to keep this child alive is what matters. So I think by now you all would have understood, because these questions written earlier. I hope if there is anything you can ask from me later even. The whole idea of quota is that you are given a value, you try to play with this, don't try to spend every drop, but if you have to spend more, you please ask for more. It is the whole message that you should bear in mind. What can we do to manage fluid overload? So that's what we have to do to manage fluid overload is to give fusimide. So it is little bit beyond your scope. Sometimes even in critical phase. Now don't go and write that in critical phase we have to give IV fusimide. Sometimes in ICU settings, in high dependency settings, we have used that. So those are actually specialized things that could be done with great experience. But of course, we have to sometimes but definitely in the early recovery phase, we actively take out fluid. But even in the height of the critical phase, for some reason or another, if the child had got fluid from there had been some sort of accident, mistake, then of course we have to take out fluid. In my career, I think I would have done it only twice or so in the middle of the management, which I've got patient inherited, but otherwise it is usually does not happen, where in the critical phase you don't have to take fluid out. But in the recovery phase, you can take it out, and you should take it out. But for that, you can use oral fusimide, which is quite safe for these children. So that is short. But on another note, addition to that, which I have not put it in the slide, and it is not actually documented anywhere, but it has been our practice. We also use, because you all know in the pathophysiology, one component is immune mediated or formation, or actually oxidative stress related. So oxygen free radicals are formed and then they are being acting in the pathophysiology of this dengue infection. It is more than the virus causing damage to the body. So because of that, we have been doing trials and we have shown that vitamin E, or any antioxidant for that matter, but vitamin E is a much more potent one. Vitamin E has reduced the as oxidative stress to some extent and actually has improved the recovery of many of these dengue patients. So as a policy in the ward and even in some other units also have seen that they use vitamin E as a measure in the prophylaxis. So in this unit, of course, any child who has been diagnosed of having dengue fever, which can progress into dengue hemorrhagic fever, we start them on oral calcium, oral omeprazole, as well as oral vitamin E for about 4 or 5 days duration. And afterwards, once they have come into the recovery phase, we stop them. And we have done all this basically based on our experience as well as data from studies that have been done in this unit. That is the additional thing apart from the other basic management that is taking place. To prevent the cytokine storm, can't we give steroids? No, steroids have been shown. There is no place in steroid management in these patients. There had been a study somewhere some time ago in Paracetamol, I think, but it was not effective. And you never use steroids because you have to make sure that you use steroids when the virus is under control. If the virus is not under control, the virus will also then multiply and there will be a little bit of difficulty in clearing the virus. So actually we have not seen the cytokine storm which we have been seeing in COVID, but of course there is oxidative stress which we are trying to counteract with antioxidants. Why we didn't start the vaccination? The vaccination is there are 2 vaccines, only one vaccine licensed, but the licensed vaccine is having a problem because if it is given to children who are not been immune before, not been exposed, the vaccine acts as the first vaccine or first infection. And then in the follow-up studies, they have come across people who received the vaccine who got dengue fever had to be admitted more frequently than their placebo counterparts. So because of that, the vaccine manufacturer has recommended only the vaccine to be given for children more than 9 years of age. And the WHO had said it should be given for populations. So based on the age category even, which are having, I think, more than 50%, 70% zero conversion in the community. So that is why it is. So the second vaccine, which is being trialed in this country, up to now has shown good promising results because we have been in the trial for more than 3 years now. But of course, it may need a third dose, which may be planning later on. So a vaccine may be possibility, but again, anyway, it will be after 2022. What is the reason for menorrhagia and dengue? No identified exact reason, of course, I can give off, but the postulated thing is it can cause, again, edema in the endometrium. So that fluid, that endometrium edema may be causing a quick breakdown in the endometrial tissue and causing it to go as the menstrual bleeding. So that is the only way I can think, but there is no identified specific pathophysiology for that. Any other questions? Somebody wanted critical chart. Any other questions? Somebody wanted the critical chart. I think I have explained it adequately. I hope you all got. If there's any question, please ask later on even. Okay, can we finish off then? Right. Thank you. Okay.